Welcome to our first video on chest trauma. Let's begin. In this lecture, we'll discuss aortic injury and cardiac contusion. For each of these conditions, we'll cover general characteristics, etiologies, clinical features, diagnosis, and management. Let's begin. Let's define and understand the general characteristics of aortic injuries. First, rapid deceleration from blunt trauma produces shearing injuries between fixed and mobile parts of the aorta, leading to a partial or complete tear of the aorta. Trauma can also lead to aortic dissection as well. The most common site of the injury is the aortic isthmus, where the aorta is relatively fixed, has weak tissue strength, and is greatly compressed between the chest wall and vertebra. Here, one can see an axial and coronal CT of the chest with IV contrast illustrating the descending type B standard traumatic aortic dissection, which one can see circled in red here. Most commonly, chest trauma gives rise to aortic dissection near the isthmus, either completely or partially. A type B dissection, as shown in this image, occurs at the descending aorta or at the arch distal to the left subclavian artery, without the involvement of the ascending aorta. When the intimal tear happens, blood enters the media and creates a false lumen, which you can see right here. Now let's move on to etiologies. Some of the common testable etiologies of aortic injury are motor vehicle accidents and falls from heights resulting in acute traumatic aortic rupture. Most of these cases result in full-thickness tears that leads to rapid hemorrhage and little time for medical intervention, resulting in death. Next, let's discuss clinical features of aortic injury. Some of the common clinical manifestations of aortic injury are chest pain due to decreased oxygenation of the coronary arteries, dyspnea, interscapular pain, and dysphagia due to esophageal compression. In terms of physical exam findings, absent femoral pulses, an interscapular murmur due to turbulent blood flow over the tear, hypertension in the upper body, and left subclavian hematoma are commonly detected. Let's talk about the diagnostic approach now. To start with, for hemodynamically stable patients with suspected aortic injury, chest CT is a diagnostic test of choice. It usually depicts either an intimal flap, hematoma, or aneurysm. Chest X-ray is also used and may show an enlarged mediastinum, tracheal displacement, or hemothorax. TEE, transesophageal echocardiogram, is another choice of diagnostic test which is most commonly used in unstable patients and depicts mediastinal hematomas, pseudoaneurysms, and lacerations. Finally, the gold standard imaging for aortic injury is aortography, during which a catheter with injected contrast is inserted in the aorta, showing the location and type of the injury. This image depicts a saccular aneurysm, arising just distal to the left subclavian artery. Traumatic aneurysms often result from car accidents when there is a compression or blowing injury of the thorax, such as when the driver's chest crashes against the steering wheel or dashboard. Next, here is a chest X-ray depicting mediastinal widening. As we've already mentioned, traumatic aortic injuries commonly result in mediastinal enlargement on chest X-ray. A patient walks into the emergency department following a motor vehicle accident, complaining of crushing substernal chest pain that radiates to his back between his shoulder blades. What is the best imaging modality to order? How would this answer change if the patient was brought in unconscious by an ambulance? As we just went over, one of the risk factors for aortic injury is rapid deceleration injury, such as in a car accident. Additionally, the common symptoms of aortic dissection include chest pain and interscapular pain. Since this patient walked into the emergency department, we can assume they are hemodynamically stable, which means a chest CT is the test of choice. If the patient was brought in unconscious, then we could assume they were unstable, and we would use TEE, transesophageal echo. Let's discuss the management of aortic injuries. Treatment will depend on the severity of the aortic injury. If there is a small intimal tear or small aortic hematoma, conservative management such as blood pressure monitoring with follow-up is suggested. When there is a more serious, larger injury such as a complete tear of the aortic wall with increased risk of hypovolemic shock, either open surgical repair or endovascular stent therapy is recommended. During these open surgical repairs, the injured part of the aorta is replaced with prosthetic grafts. During endovascular procedures, a stent is inserted in the aortic from the groin and is expanded in the injured area to prevent further bleeding. Now that we've discussed aortic injuries, let's move on to cardiac contusion. First, let's define and understand the pathophysiology of cardiac contusion. Bruising of the myocardium due to decelerating force, direct or indirect pressure to the chest wall, results in myocardial contusion with LV dysfunction and possible cardiogenic shock. More specifically, a blow to the chest wall most commonly impacts the right ventricle, as it is directly behind the sternum. This blow to the chest can decrease the anterior-posterior diameter of the chest, causing the interventricular septum to shift and decrease the compliance of the left ventricle. The net effect of these changes is a decrease in preload and cardiac output. Now let's talk about etiologies. Some of the high-yield ones are chest compressions, motor vehicle accidents, and fall from heights. Anything causing blunt trauma to the chest can lead to bruising and disruption of the heart's normal pumping function. Next, let's discuss clinical features. Classically, patients with myocardial contusion report pain above the ribs, bruising over the chest and upper abdomen, nausea, vomiting, and dyspnea. Patients may also present with arrhythmias or tachycardia. Arrhythmias can disrupt systolic function and lead to the development of acute heart failure. Now let's understand the diagnostic approach. To start with, a definitive diagnosis of the myocardial contusion is possible only on gross examination. Therefore, the following tests cannot clearly identify the contusion but can detect the possible complications of the injury. The initial test recommended in a patient with cardiac contusion is a 12-lead ECG, which can evaluate for possible arrhythmias such as AV blocks or bundle branch blocks and ST changes. Troponins can also be done as a screening for myocardial injury. If ECG and troponins are normal, the patient has a minimal chance of having myocardial contusion and can be discharged. On the other hand, if ECG is abnormal and troponins are positive, TTE or TEE is recommended to further evaluate general cardiac function along with ejection fraction, wall motion, and valvular function. Finally, chest X-ray and/or CT scan are indicated if further injuries of the chest wall are suspected, including the ribs, lungs, or sternum. A patient with history of recent myocardial infarction requiring numerous chest compressions returns to the emergency department and is diagnosed with cardiac contusion. What is the pathophysiology behind how this patient's current condition occurred? What are the effects on preload and cardiac output? The patient recently underwent numerous chest compressions as part of the management of their myocardial infarction. Even though the chest compressions were necessary, they still put a repeated force on the chest wall and the heart underneath, which lead to a contusion of the myocardium. This pressure on the chest decreases the anterior-posterior diameter of the chest, which causes the interventricular septum to shift and the compliance of the left ventricle to decrease. All the above changes lead to a decrease in preload and cardiac output due to the decreased compliance of the left ventricle. Now let's cover the treatment options for a myocardial contusion. To start with, management depends on the severity of the injury. For example, if a patient has dyspnea, supplemental oxygen is recommended. If there is bleeding in the chest tube placement for drainage is suggested. However, if the patient is bleeding into the pericardial space, leading to cardiac tamponade, pericardiocentesis is recommended. Next, if the patient develops abnormal rate and rhythm, advanced cardiac life support measures should be applied for any life-threatening rhythm, or the patient should be monitored with cardiac telemetry for any minor rhythm abnormalities such as premature ventricular contractions. Finally, if there is valvular damage, surgical repair will be the next best step in management and cardiology should be consulted as soon as possible. A 25-year-old athlete is brought to the emergency department due to severe chest pain after being involved in a motor vehicle accident 30 minutes ago. Rapid deceleration led him to hit his chest against the steering wheel. His past medical history and family history are non-contributory. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 80/60, and heart rate of 125. And respiratory rate of 21. The physical exam reveals a large precordial bruise. ECG shows nonspecific ST T-wave changes. Troponin 1 is 1. Which of the following is the most likely diagnosis in this patient? A. STEMI, B. NSTEMI, C. Unstable angina, or D. Myocardial contusion. This young athlete presents with severe chest pain after being involved in a motor vehicle accident 30 minutes ago. Rapid deceleration led him to hit his chest against the steering wheel. His vital signs are significant for hypotension with the blood pressure of 80/60, tachycardia with the heart rate of 125, and tachypnea evidenced by respiratory rate of 21. Physical exam reveals a large precordial bruise. ECG shows the nonspecific ST T-wave changes. Troponin 1 is 1. All these findings within the context of chest trauma in a young patient suggest the diagnosis of myocardial contusion. Myocardial injury due to contusion can induce ECG changes and increase troponin levels. Therefore, the correct answer is option D. Here is a slide reminding us of the diagnosis of cardiac contusion. Pause the video and take a moment to consider this slide once more. Let's discuss why other options are incorrect. Option A is incorrect because ST elevation, myocardial infarction, also known as STEMI, is characterized by ST elevation on ECG. This patient, in contrast, has the non-specific ST T-wave changes. Option B is incorrect because non-ST elevation myocardial infarction, also known as NSTEMI, is very unlikely in a 25-year-old athlete without positive family history and genetic predisposition. Finally, option C is incorrect because unstable angina does not lead to increased troponin levels. And that concludes this section.